Good afternoon and welcome to our congressional briefing and national webinar on the report Ready or Not 2022, Protecting the Public's Health from Disease, Disasters, and Bioterrorism, hosted by Trust for America's Health, or TFAH for short. My name is Tim Hughes, the External Relations and Outreach Manager at TFAH. We would like to thank our speakers and audience for being with us today. Real-time captioning is provided today by Jenna Lee and Marielle from AI Media. For captions, click on More at the bottom right of your screen with the three dots. Next, click on Close Caption. We encourage you all to share your thoughts and questions about today's presentation by typing them in the Q&A box. We'll try to answer as many as we can as time permits. To open the Q&A box, click the Q&A icon at the bottom on your screen. From there, select Enter when you are ready to submit your question. And now it is my pleasure to introduce the moderator of this event, Dr. J. Nadine Gracia. Dr. Gracia is the President and CEO of Trust for America's Health. She is a national health equity leader with extensive leadership and management experience in federal government, the nonprofit sector, academia, and professional associations. As president and CEO, she leads TFAH's work to advance sound public health policy, address the social determinants of health, advance health equity, and make health promotion and disease prevention a national priority. Welcome, Dr. Gracia.
Thank you, Tim, and greetings, everyone. As Tim stated, my name is Nadine Gracia, and I'm the President and CEO of Trust for America's Health. We are so pleased that you are joining us today for this congressional briefing and national webinar. And I'd like to thank our esteemed panelists for taking time out of their busy schedules to participate in this event. We are certainly honored to have them join us. Next slide, please. So on this slide, you'll see the agenda for today's briefing. And after each of the panelists provide their presentations, we'll have time for question and answers from the audience. Next slide, please. So before we turn to our panel, I'd like to review some of the findings and the recommendations from TFAH's recently released 2022 Ready or Not report and our vision for a more resilient nation moving forward. Since 2003, nearly 2 decades, TFAH has published the annual Ready or Not report, which assesses states on 10 priority indicators. Now, these indicators are intended to be a checklist of actionable steps that states can take to improve their overall readiness. It's not intended to be a report card or a grading of states, but rather gives states tools for improving preparedness across a range of issues. These indicators involve actions by numerous stakeholders, including policymakers and public health departments, the healthcare system, employers, and the general public. In this year's report, we highlight the tragic lessons of the COVID-19 pandemic, including steps that policymakers and other decision makers can take to improve our nation's health security. And as in all of our reports, we include evidence-based policy recommendations for different sectors. We found that there has been progress over the past 2 decades, but what the pandemic has clearly illustrated is that there is much more work to be done everywhere to protect the public's health during major events. Next slide. So our report measures states' performance on 10 key emergency preparedness indicators across a range of emergencies, not solely infectious disease outbreaks, but also weather-related emergencies and other types of emergencies, and across a range of sectors from hospitals to public health to state governments. And we've found progress as well as areas of improvement in every jurisdiction. In this year's report, we found that 17 states and the District of Columbia were in the high performance tier, which is demarcated by the green shading. 20 states were in the middle tier, which is in orange, and 13 states were in the low tier, which is in red. Overall, 12 states improved their performance, while 16 states slipped in their ranking. And all states' performance is relative to that of other states. Next slide. So when we look at some of the key findings as it relates to areas of performance strength, we know that all states had a plan in 2021 for a 6 to 8 week surge in their laboratory testing capacity to respond to an outbreak or other type of public health event. While only the District of Columbia reported not having such a plan, but that plan in the district was in progress in the development phases. We also noted that accreditation in public health and emergency management are important tools of measurement, of quality improvement, and accountability. And we found that most states are accredited in one area or both. More states have also joined the Nurse Licensure Compact over the past few years, which makes it easier for healthcare facilities to bring nurses across state lines during a medical surge. 37 states now are in the Nurse Licensure Compact, which is a net increase of 11 since 2017. And we've seen a promising increase in seasonal flu vaccination rates in recent years, holding over 50% for the second season in a row. And this is an important measure of how well we are vaccinating all age groups. The vaccination rate for Americans ages 6 months and older rose from 42% during the 2017 to 2018 flu season to 52% during the 2019 to 2020 season. And while that's progress, we're still well below the 70% target vaccination rate that's been established by Healthy People 2030. Next slide. So there are certainly also areas where there are opportunities for improvement. Critically, we know that funding for public health systems by both the federal government and state governments needs to increase. Decades of chronic underfunding of public health has put the public safety at risk. We need to invest in rebuilding the public health workforce, systems, and technologies. The Staffing Up Project estimates that state and local health departments need at least 80,000 more full-time equivalent public health staff to provide foundational, basic public health services. And only about a half of the US population is served by a comprehensive public health system. Without new and sustained funding, the nation is at risk to confront the next health emergency with the same challenging manner in which we have done during the COVID-19 pandemic. We've also found that a majority of hospitals did not achieve the highest patient safety grade. And this demonstrates the importance of healthcare in protecting patients and staff, not only during non-emergency times, but also during crisis or emergency. And only about half of workers used any time of paid leave during a given month in 2021. A lack of access to paid leave is particularly problematic during a pandemic when having people who are sick or exposed to the virus should stay home is critical to keep the infection from spreading. Next slide. Now, our report also examines the lessons learned so far from the COVID-19 pandemic, and we know that we're continuing to learn lessons in this pandemic. While all communities have experienced the pandemic, we know that it did not impact communities equally. Communities of color, people with disabilities, households with low income, older adults, and others often bear disproportionate burden and do not necessarily receive response services adequately. And we're seeing an example of that as funding for free COVID-19 testing diminishes. Americans who are uninsured are being asked to pay out of pocket. So equity must be central in public health preparedness and response. The pandemic has also put a spotlight on a public health system that has been hollowed out by years of insufficient funding. And while state and local health departments have courageously worked on the front lines of this pandemic to protect the public's health, funding shortfalls have really created significant barriers to sufficiently responding to the pandemic. We need public health infrastructure funding for shoring up the workforce, our laboratories, and data systems. COVID-19 emergency funding, while it has been critical, it was one time and not a solution to chronic underinvestment. And certainly we need strong federal and state leadership that's coordinated with clear roles and responsibilities, which is vitally important for our future emergencies. Next slide. One reason why this past year has been so difficult has been the lack of investment in our public health system. As noted before, the COVID-19 response funding has been critical, but when we're pouring money into systems that have been eroded over the past decades, these systems really can't be built overnight. What this chart shows are the two primary funding sources for public health emergency preparedness systems in our country: the Public Health Emergency Preparedness Program, known as PHEP, and the Hospital Preparedness Program. The Public Health Preparedness Program, which appears in blue, these are dollars from CDC to state, local, tribal, and territorial health departments for building the foundations of emergency response. And the Hospital Preparedness Program, which appears in red, are grants to states to develop healthcare preparedness, including healthcare coalitions. FAPA, unfortunately, has been cut by about 26% since 2003, or 48% if you account for inflation. And the Hospital Preparedness Program has been cut by 46%, or over 62% if you adjust for inflation. And what these long-term erosion of funds mean is that we lose workers, expertise, and the systems can't modernize. And that's what we saw with some health departments, for example, that were tracking COVID-19 cases with phone and fax instead of modern information systems. Next slide. So we see this kind of boom and bust cycle of public health funding, which is a repeated cycle that we've seen in most levels of government and in many past public health emergencies. You know, when public health is doing its job, communities are thriving and healthy, and most Americans are unaware of the role of public health. That's the same is true for lawmakers, the decision makers who control budgets for health departments or other public health agencies. And as a result, we see federal and state public health funding erode over time. But then when a crisis happens, such as COVID-19 or Zika or Ebola, if that crisis is big enough, Congress may appropriate money for the response. But then as the crisis fades from the headlines, funding starts to stagnate again. And what this means is, again, we are pouring emergency funding on top of a depleted system. And when that emergency funding expires, much of the workforce that's been hired will be let go. Funds start to stagnate and we're right back where we started. And so we must learn the lessons of the past public health emergencies and certainly this pandemic and ensure that we are sustaining and modernizing public health, not just during a disaster. Next slide. In the 2020 Ready or Not report, we outlined several policy recommendations, and I just highlight a few of our key federal recommendations here. We certainly need to get out of the boom and bust cycle of public health funding, and that includes increased annual funding for programs like the Public Health Emergency Preparedness Program, but also importantly, direct and sustained and flexible funding for cross-cutting public health infrastructure and workforce, such as infrastructure and data modernization. And both of these, for example, have been proposed for funding increases in the president's budget. As we noted earlier, equity must be central to preparedness and response efforts. And the presidential COVID-19 Health Equity Task Force laid out numerous specific recommendations for improving health and resilience of communities. You know, federal agencies should ensure that there's meaningful engagement of communities, that there are resources that are reaching community-based organizations. And investments in health equity and social determinants of health have to be prioritized to help build resilient communities, including incorporating equity leadership into preparedness and response and ensuring that funding is reaching the communities that are experiencing disproportionate impact. Congress should also pass protections for paid sick, family, and medical leave, because guidance to stay home when sick is not possible for many Americans who just can't afford to miss a paycheck or possibly even lose their job if they miss work. We need to invest in end-to-end research and development, as well as the infrastructure to distribute medical countermeasures such as vaccines and therapeutics, and educate the public and providers about their use. And policymakers and healthcare leaders also need to prioritize the readiness of the healthcare system for all types of emergencies, including through increased funding for the Hospital Preparedness Program. And we certainly have seen the importance of having effective public health communications at all levels. We need to ensure that there is an effectiveness of those communications, including research into best practices and effective messages for diverse audiences and addressing misinformation. And finally, we recommend that Congress create and fund an independent commission to investigate the pandemic preparedness and response and make concrete recommendations for addressing the gaps. We're still certainly learning the lessons of the pandemic, and such a commission really could help to provide a blueprint for policymakers and practitioners moving forward. Next slide. So you can access our full Ready or Not report and its findings and recommendations on our Trust for America's Health website with the link provided directly here. And we encourage you to also follow us on social media at Healthy America One. And I'm now going to turn us to our panel to start our presentations, and then we'll move into our discussion. We're going to save questions until after all of our presenters deliver their presentations, but just a reminder to please submit your questions in the Q&A box, not the chat, and we'll respond to as many questions as possible during our Q&A period. I am now pleased to welcome our distinguished panel of speakers with us today. First, Dr. Leandra Sliberg, who is the Associate Director for Minority Health and Health Equity for the Centers for Disease Control and Prevention and the Agency for Toxic Substances and Disease Registry, or CDC-ATSDR. In this role, she provides agency leadership, direction, and accountability for CDC's policies and programs to ensure that they are effective in improving minority health, health equity, and women's health. She has a critical leadership role in determining CDC's vision for health equity, and she also served as CDC's first ever Chief Health Equity Officer during the COVID-19 response. Our second panelist is Dr. Thomas Dobbs, who is the State Health Officer for Mississippi, and in that role led the state response effort to COVID-19. He is an infectious diseases physician working at the intersection of public health and patient care, both domestically and internationally, with specific expertise in HIV, tuberculosis, and health equity. Dr. Dobbs has served in other public health roles, including district health officer and state epidemiologist in Mississippi. And Dr. Dobbs also serves as an associate professor at the University of Mississippi Medical Center teaching epidemiology at the School of Population Health. Our third panelist is Dr. Celine Gounder, who is a senior fellow and editor at large for public health for Kaiser Health News at the Kaiser Family Foundation. Dr. Gounder is an internist, infectious disease specialist, epidemiologist, and medical journalist and thought leader. She's a frequent expert guest on national television and has written for the New York Times, the New Yorker, the Atlantic, the Guardian, the Washington Post, and Reuters, among other publications. She's best known for her coverage of the Ebola, Zika, COVID-19, opioid overdose, and gun violence epidemics. So as you can see, we have truly a wonderful and distinguished panel of speakers this afternoon to have this important conversation. So now it is my honor to turn to our first presenter, Dr. Leandra Sliberg from the CDC. Welcome, Dr. Sliberg, and I'll turn it over to you.
Thank you, Dr. Gracia, and good afternoon, everyone. Can we go to the next slide, please? I also want to thank TFAH for inviting me to join you today. And I will speak with you about the important role that health equity plays to strengthen the nation's public health systems. Next slide, please. Next slide. So I'd like to set the stage for why I'm here today to talk about the pursuit of health equity as an agency-wide priority for CDC. At CDC, we are committed to addressing health disparities in the United States. Our overall mission is to protect Americans from health, safety, and security threats, both foreign and in the United States. And we cannot possibly meet that mission without addressing health disparities that permeate our entire country. While we at CDC have been working to address inequities at various levels and in various parts of the agency, I believe we are in an historic moment. We have the opportunity to make holistic, transformative progress. Over the last 2 years, the world, our nation, and our agency have been waking up to systemic inequities. 1 year ago, for the first time, CDC declared racism a serious public health threat. And many of our partners are amping up their efforts in health equity as well. Next slide, please. This is language from a presidential executive order regarding equity. In addition to this executive order, there are other mandates and action items stemming from this and other policies. In non-emergency times, CDC works to address health inequities rooted in racism, including scientific research, community programs, policy efforts, and workforce development. And through this work, we aim to better understand social determinants of health and combat the racial and ethnic health inequities illuminated throughout the COVID-19 pandemic and in future public health emergencies. CDC works with public health partners to reduce and ultimately eliminate racial and ethnic inequities in health by addressing the structural and social conditions that give rise to them. Next slide, please. As an agency, CDC is transforming its public health research, surveillance, and implementation science efforts to shift from simply listing the markers of health inequities to identifying and addressing the drivers of these disparities. In 2021, CDC launched a core health equity science and intervention strategy that's designed to work in collaboration with partners to transform our work at its very core and strengthen our ability to keep our nation safe and healthy today and in the future. This new strategy has a vision of health equity and challenges our CDC centers to incorporate health equity and efforts to address health disparities as a foundational element across all our work, from science and research to programs, and from partnerships to workforce. Next slide, please. Throughout the COVID-19 response, CDC has worked with national, state, tribal, local, territorial, and community partners to promote vaccine equity. To support these partnerships, CDC has provided funding for organizations that reach racial and ethnic minority groups. Some examples of this funding include $3 billion awarded to 64 jurisdictions to support local health departments and community-based organizations in launching new programs and initiatives to improve vaccine equity. $2.25 billion also awarded to health departments across the United States and its territories to work in collaboration with community partners to address COVID-19 health disparities. And $348 million to organizations for community health worker services to support COVID-19 prevention and control. And $32 million to organizations for community health worker services to support training, technical assistance, and evaluation. Next slide, please. And next slide. So ensuring health equity is not only essential to ending a public health emergency such as COVID-19, but critical to saving lives. To meet this need, the first Chief Health Equity Officer unit was established early in the COVID-19 response structure, with the sole focus of ensuring an all-of-response approach to identify actions aimed at addressing health disparities and inequities. The CHIO, as we refer to it, performed efforts that align with HHS's strategy for racial and ethnic minority populations and the long-term plan for recovery and resilience of social, behavioral, and community health. This also redoubles CDC's commitment to diversity, equity, and inclusion to achieve our public health mission. Having CHIO in a key leadership role provides health equity champions more direct access to funding, relationships, and influence spheres required to successfully implement strategic health equity initiatives. Next slide, please. The CDC COVID-19 response health equity strategy was developed under the leadership of the Chief Health Equity Officer to afford a robust platform from which CDC and its partners pursue deeper engagements with diverse communities, where they created stronger infrastructures to better support data-driven action and increased culturally responsive approaches optimized for serving diverse, differentially impacted populations in different areas. COVID-19 may exacerbate already existing health and social inequities. Data highlights groups at increased risk of COVID-19 that include racial and ethnic minority populations, people experiencing homelessness and substance use disorder, persons with disabilities, those who are incarcerated or detained, and people born in other countries, as well as people living in rural and frontier communities. Racial and ethnic and other minority populations at high risk for COVID-19 face unique circumstances, and effective public health intervention planning accounts for the particularities of the populations to increase the chances for success. Cultural and linguistic needs may determine the success or failure of a public health intervention strategy. So as we continue to learn more about the impact of COVID-19 on the health of different populations, continued action is critical to reduce COVID-19 disparities among the populations already known to be at disproportionate risk. Next slide, please. At CDC, we are committed to addressing racism as the root cause of racial and ethnic disparities in the United States. Across the agency, there is an ongoing and vibrant body of work to address health inequities through a range of key initiatives, including health equity strategies and funding for health departments, science and research, policy initiatives, addressing social determinants of health, community programs, and workforce and pipeline efforts. One example, which you have hopefully seen, is CDC's Racism in Health website, which will be a hub for CDC's activities on health equity related to race and ethnicity. Next slide, please. We all have a part in helping to promote fair access to health to advance equity, both now and in future public health emergencies. To do this, we have to work together to ensure that people have resources to maintain and manage their physical and mental health, including having easy access to information and affordable, high-quality medical care. And addressing these differences through new approaches that consider the impact on different groups. Some examples include understanding how differences in access affect communities, developing and implementing approaches to address these differences, considering their impact on different groups, mobilizing community engagement and support, identifying inequitable conditions in the social environment, and changing community dynamics to support health, as well as implementing public health policies that address underlying causes of health inequities. Next slide, please. And next slide. I won't take the time to go through all of the resources that are available on our Health Equity in Action webpage, but I do encourage you to visit that website. This is an important communication tool that can serve as a resource for partners, media, policymakers, and anyone else interested in CDC's health equity efforts during the COVID-19 response. Next slide. Before I close, I want to invite you all to connect with CDC's Office of Minority Health and Health Equity. Our office uses various platforms to share information and promote meaningful engagement with public health practitioners, academics, and others interested in advancing minority health and health equity. And we encourage you to connect with us through these newsletters, blogs, as well as the social media platforms. Next slide, please. Thank you for your attention, and I look forward to the discussion later on in this gathering.
Thank you, Dr. Sliberg, for such an informative presentation, and looking forward to our dialogue and discussion around CDC's efforts in preparedness and in equity. We're going to turn things now over to Dr. Thomas Dobbs from the Mississippi State Department of Health. Dr. Dobbs, I'll turn it over to you.
Thank you, Dr. Gracia, and thank you, Tifa, for having me join you. So my title slide, it's something that we may not have paid attention to recently, but we have been expecting a pandemic. People always ask me, said, can you believe that you had a pandemic? And I would say yes, because we've been talking about it for years. And we had planning documents, and we had pandemic severity indexes with anticipated mortality. And if you look at the pandemic severity index that we reviewed going into this pandemic, and we knew that the mortality rate based on initial data probably put us around a category 2. We had predicted that we would have lost maybe 200,000, 250,000 people across the country based on the severity of illness. But when we consider what's happened in this country, we've lost 1 million plus people, right? We have lost hundreds of thousands of people that did not have to die. And that if we're not have our hands up in fury about this unnecessary loss of life, I don't know what would get our attention. It's really been a tragedy. And the slide below is the mortality rate in Mississippi in the successive waves, and we've lost over 12,000 people in my own state. Next slide, please. If we look at what's happened in Mississippi, we have lost over 12,000 lives from COVID, and that's clearly an undercount. Over 1,000 people under 50 years of age. So it's not just older folks. 1,000 people, think of that, 13 children, all of whom were unvaccinated, most of whom died after vaccines were available for their age group. Tragedy that could be prevented. But I think if we look at this in context, let's see how many Mississippians were lost during the Vietnam War due to the war. 637, or World War II, which was obviously, you know, the deadliest war in our past century, 3,500. So the pandemic is about 4 times more deadly than our most deadly war that lasts 4 years. You just see a little bit of the impact that it's had on our state, but also our country. Next slide. So we face many challenges. And one of the things that we run into a lot, and I've spoken on panels multiple times, is we need better infrastructure. And as an analogy, just imagine that when you have a challenge and you want to grow a crop and you have seeds, you need to have fertile soil, fertile ground, so that when you plant the seeds, you can reap the benefits of that investment. But what we have is we have depleted and exhausted soil in our public health infrastructure. And then we throw lots of seeds on top of it, but we don't get the results that we need. It's because we haven't had that steady supported funding, that we have a resilient operation that's ready to react. We have underfunded operations. We have siloed and restricted funding that I'll talk about a little bit. It's not just sort of like our sort of response funding, but it's everything. It's going to be, you can't use STD money to help with HIV and vice versa, and prevention is not the same as treatment. We have everything so precisely siloed that we are limiting ourselves in the resources that are available to us to solve universal problems. We have short-term siloed and reactive planning. When we look at what happens with COVID and other events of previous but lesser magnitude, the health department or the public health response units are active for months before funding's available, right? And then we have to spend a lot of money trying to build new systems on top of what we've cobbled together off no funding to have a reasonable response. Funding is often overly prescriptive and does not meet community needs. And that's one of the things that we've realized in the pandemic is when we're working with communities, we sit down and ask them first, what do you need and what will work for you? What we've had a lot with the pandemic also is, as an example, we were told that we needed to have a massive drive-through center that was funded through FEMA. Well, we already had them built, and they said, well, we want you to have it anyway. And they said, well, we don't need them. We've already built them. We don't need to disassemble them. And we basically wasted a lot of time trying to get a resource integrated that we didn't need. We also have an underdeveloped workforce. Remarkably, Mississippi has a smaller public health workforce now than we did in 2019, in spite of all the funding and all the new positions that have been made available to us, we are at lower. Now, keep in mind, this graph is not to scale, right? So it's not that much lower, but it's declining. And you would think with this investment, we should have a more robust health system, but it's worse. We have severely uncompetitive salaries. And a lot of that has to do with state issues, but still, those are things that have to be addressed if we really want to have a resilient public health system. Next slide. When it comes to nursing, which are a core operation for public health in most states, if we look at what's been happening over decades, since 2000, we're down almost half of the nurse workforce that we had before. Nurses are shortage. I get it. It's hard to come by nurses. But in public health, where we really depend on this specialized training, we're even lower in 2022 than we were in 2020. And I don't know that our current plans are going to get us where we need to be with our current sort of structures. Next slide, please. And this is, again, this is more national data from the de Beaumont Foundation, and you can see across the country, the number of public health workers has declined at a time when we need them most. We have to have a global strategy that gives us a firm and resilient public health workforce. Next slide. So these are some of the public health threats that I've dealt with in my time in public health. And this is not all of them. There have been other ones, but you can see West Nile, Zika, chikungunya, H1N1, Ebola, and COVID. And they all have one thing or several things in common. I mean, they're threats to the general population, right? So it's the same sort of public health infrastructure that you need to do a lot of the same stuff. But what has happened universally is we've had a depleted public health workforce that had a new charge that we had to ramp up. We had to borrow resources from other important operations like family planning or HIV prevention and treatment so that we could respond. And then we would get a lot of money, right, a little bit too late, that would then fund for a long time beyond the period of need. And then we couldn't use that money for anything else because it was siloed for Ebola. We spent years with Ebola money trying to figure out how we could use it to build public health infrastructure, but it was very difficult because the money was so siloed to Ebola, we couldn't make it work for the general public health infrastructure. I would like for you to picture an army of the United States that is allowed to only fight certain countries because they are siloed in funding, right? It's the same thing with public health. The threats are universal. You never know what the next one's going to come from. And we really have got to have a more robust, broadly funded, prospective, forward-looking public health infrastructure so that we can respond to the threats of tomorrow, not the threats of yesterday. And that's all I have. Thank you very much. Oh, and this is actually one more thing I forgot. Go back. So one of the things that Dr. Byers and I always laugh about, who's an epidemiologist, is this is my own sort of paraphrase from Men in Black, where they're always seeing external threats. There are always external public health threats. People don't know about them, and we know about them, and we know the public's at risk. But just because they're not getting attention doesn't mean they're not there.
Thank you, Dr. Dobbs, for that wonderful presentation. Looking forward to our discussion shortly. We're going to turn it now to our third speaker and panelist, Dr. Gounder. Welcome, Dr. Gounder. I'll turn it over to you.
Oh, thank you so much. And it's really an honor to be here with all of you today. I thought I would start with a bit of an update from the headlines and then focus on a couple key issues that I think are worth highlighting. So first of all, many of us have been asked, what is the BA2 Omicron subvariant going to mean for all of us? And I think we still do not have the answer to that for the US population. I think we'll have a much better sense within another week or two, but we do have other places we can look to help us predict that, foreshadow what's to come here in the United States. And I think two of the places I look to are the experience in the UK and also how things are playing out here in New York City. And what we saw from the UK is a country that is really well vaccinated relative to most of the United States, also more vaccinated and boosted among their elderly. One key difference between the UK and the United States is that the UK made much more use of what are called adenovirus vector vaccines in the form of the AstraZeneca vaccine. The AstraZeneca vaccine is not as effective as the vaccines that we've been using here in the United States. So that is a significant difference even though they are better vaccinated, at least some of their population is vaccinated with a less effective vaccine. And yet they saw an increase in cases, hospitalizations, and deaths in the UK as a result of the recent Omicron subvariant. And what we are seeing here in New York City, which is also very highly vaccinated relative to the rest of the United States, we have vaccination rates up into the mid 70s, and our elderly are also well vaccinated, although less well boosted and less well vaccinated than in the UK. We have seen an increase in cases. We also have seen an increase in hospitalizations and deaths, specifically among those who are not vaccinated. And we saw those numbers of cases trend up and then very recently start to go down again. And that's across the board for vaccinated and unvaccinated. And that may be a reflection of the fact that people's behavior changed. I have heard of more cases of COVID recently, infections recently, than I have really at any point in the pandemic. So I think what we may have seen is a combination of people seeing transmission in their own community, perhaps tightening up their behaviors. The other possibility is that we saw this new subvariant really running through those who were susceptible. So those who had some degree of waning immunity from their most recent vaccination dose or from a prior infection, that it raged through perhaps those people and hit a wall of immunity after that. We don't have an answer as to which scenario that is. But the good news is we are seeing cases trending down now in New York City. How this will play out in the rest of the country, though, remains to be seen, particularly given most of the country is not as well vaccinated, not as well boosted, and in populations that are older in particular, have perhaps higher rates of underlying comorbidities. This could still play out poorly for many people. And I do think where vaccination rates and boosting rates are low among the elderly, we really do need to be concerned. There may still yet be a surge in hospitalizations and deaths to come in the subsequent weeks. Some have, there are concerns about the vaccines that we have. I'm hearing some saying, well, part of the issue is that this is really about the vaccine technologies we've used. I don't think that's really the issue here in terms of breakthrough infections. I think we have a combination of a virus that has mutated very rapidly, and some of the predictions modeling as to how quickly this virus will continue to mutate, some of those models are shifting now. And that remains to be seen. Are we going to see a slower step-by-step rate of mutation, or are we going to see big jumps in mutation as we did with Omicron? And we don't have a good answer to that yet either. I think what we do know is we are going to need new vaccines, new technologies in particular, that complement the existing vaccines, like our mRNA vaccines. Some of that might be in the form of mucosal vaccines. So those would be intranasal or oral vaccines to improve the immunity on our mucosal surfaces, on the linings of your airways. You may also see developments in the form of skin microarray patch vaccines, where again, you're eliciting a better mucosal immune response. And then finally, trying to anticipate how the virus may mutate in the future, and trying to get ahead of the virus, developing universal coronavirus vaccine. So I do think there's still a lot of work to be done with respect to vaccine development. And it's not a criticism necessarily of the current vaccines, but we do need to stay ahead of this. Also in the news this week is Paxlovid, the antiviral pill for COVID, and the administration's test to treat program. So Paxlovid is a pill that can be taken for treatment of COVID. It is highly effective in preventing progression to severe disease, hospitalization, and death if taken early in the course of disease, so soon after infection or soon after symptom onset. The challenge has been that the supply of Paxlovid has been quite limited up until recently. And even now, as the supply is opening up, access remains an issue. And this is for a number of different reasons. One, we have a broken system of primary care in this country where 1 in 4 people in this country do not have a primary care provider. And even if they do, may not have a consistent relationship with that provider. If they try to get an appointment soon after, say, developing symptoms, they may not be able to get an appointment within the 3 to 5 day window when getting a prescription for Paxlovid would have an impact. As for the retail pharmacies that have also stepped up to try to provide Paxlovid through the Test to Treat program, that still does require a test, a licensed provider being able to evaluate that patient and the appropriateness of taking this medication and dispensing that medication. And not all pharmacy sites have those providers. One possibility would be to try to have more of these responsibilities shifted to pharmacists themselves through standing orders, but that still will require building up a system to do this safely. Federally qualified health centers have played an important role in vaccinating people, really should also be playing an important role in providing treatment. But again, that will require building up capacity, training providers. One of the issues that we're facing right now is many providers are still confused about who is eligible for treatment with Paxlovid, who is not eligible, how quickly you need to provide the medication, what are some of the drug-drug interactions. And very often when people are confused, the easiest thing is simply not to prescribe. And so this is another obstacle we do need to address here. And finally, as somebody who worked in public health myself, I think back to over a decade ago after the last recession, when I was running the TB program here in New York City and was really having to face some very difficult decisions about whether to keep our TB clinics, all of them open, or perhaps close some of those because of the funding cuts we were facing. And I think this is a moment, seeing the difficulties we're facing with Paxlovid and treating people, understanding all of the obstacles there, that you can't treat somebody if you can't test somebody. 10% of Americans do not have health insurance. As I said earlier, 1 in 4 do not have primary care. It's going to be very difficult to get people treated through our routine healthcare system. And there's a very important role for public health clinics, whether that's for treatment of tuberculosis and sexually transmitted infections or for COVID. And this may be part of what we need to be thinking about in the future, is providing treatment through public health clinics for COVID. Now, those are some of the issues top of mind in the headlines. I also want to shift gears a little bit to highlight a couple other issues. One around metrics, how we measure the pandemic. And many of us were concerned, I think, when in January, the CDC moved its measures of community risk from simply looking at community transmission to then focusing on a composite measure, really, of cases, hospitalizations, and hospital capacity. And the concern many of us have is that the way that has been communicated by the Centers for Disease Control and Prevention and others in the administration is that we saw these maps of the country dramatically shift from much of the country on fire with transmission to most of the country supposedly being low risk. And what those maps really indicate is how stressed is the healthcare system in those parts of the country, in different states, different counties. And if you were to get COVID, how likely are you to receive routine standard of care or crisis standards of care? And I think the challenge here is that as public health providers, we want clear, simple, easy to understand messaging. But one metric is not the right metric for every single question. You need to match the metric, the measure, the outcome to the question that's being asked. And for the average citizen, when you are asking what is COVID risk in my community, what you're really asking is, if I go out without a mask, without taking any special precautions, how likely am I to get COVID? That's really what the average person is asking. And that's not what that current metric of COVID community risk really indicates. Now, that said, there is a place for looking at hospitalizations and deaths as a measure. And I think what some of us have advocated is that is the appropriate metric for assessing, for example, your vaccination program. How well are your vaccines working? Or your vaccines in combination perhaps with other mitigation measures, how well is that package working to reduce hospitalizations and deaths? But I think we need to be careful in matching the question to the measure. Another approach that some of us have advocated is, instead of focusing just on COVID, to be starting to look at composite metrics of all viral respiratory infections. So for example, influenza, RSV in combination with COVID. And if you think about, again, matching your intervention with your measure, if you have an intervention that prevents multiple infections, for example, masking or improving indoor air ventilation and air filtration, testing and treatment. We could be bringing along influenza with COVID in terms of being more aggressive about testing and treating patients. Very often, patients are not treated with drugs like oseltamivir, also known as Tamiflu, when they could be. And so we have these missed opportunities, and thinking about our interventions as not just against COVID, but against a number of different viral respiratory infections, measuring that accordingly and communicating that, I think would also go a long way towards making better use, more efficient use of these different interventions in tandem and parallel. Another example of this would be looking at indoor air quality and the impact on health of children in schools. We have seen a decrease in asthma flares, asthma attacks as a result of decreased viral transmission of all sorts. And really looking at those kinds of measures, again, as a composite would be very powerful here. The other key issue I wanted to highlight is this shift from public health to clinical, or collective versus individual. And the challenge with that is when you do not have equal access, equal availability, equal, for example, a cost, do you have to pay out of pocket? Is it something that is free and cheap and convenient for you to use? Is it easy for you to use? Do you have health insurance to cover that? Do you have health insurance to cover your provider? In the absence of that, you are putting the onus on the most vulnerable to be caring for themselves. I liken this, for example, to when you go to the grocery store, do you have candy right by the checkout aisle or not? And that makes a big difference. When you make something, a healthy behavior, very easy, people are more likely to adopt it. And so in addition to having these tools now innovated and created, whether that's vaccines or treatment or testing, we need to make them more readily available. And so that would include everything from health insurance. So during the pandemic, we have seen more people enrolled on Medicaid, but when the public health emergency expires, there will be a churning off the rolls. There will be fewer people who will be remaining on Medicaid. During the public health emergency, we've had more generous subsidies for people to buy into the Obamacare marketplace plans. Those will also expire and will go back to the original level of subsidy. And 1 in 10 Americans still does not have health insurance. Many Americans do not have paid sick and family medical leave, which means that it costs money to stay home when you're sick. It costs money to stay home and take care of a child at home rather than sending that child to school. There are costs to caregiving, whether it's caregiving for a child or an elderly adult, and these do not fall on everybody equitably. And so if we are to make this move from public health to clinical, it really does mean, one, having more equitable healthcare systems, which right now our healthcare system very predictably exacerbates health disparities. And secondly, to have safety nets, whether that is paid sick and family medical leave, more generous health insurance, disability, caregiving supports, and the like, to catch those who fall through the cracks of our healthcare system. I think in the interest of time, I will pause there and turn it back over to our moderators.
Great, thank you, Dr. Gounder, for that presentation and in particular also on what's in the headlines now and talking about what's in the news and the uniqueness of the career that you have of the public health and medicine and journalism, which really to help highlight these critical issues. So we are going to conclude our panel presentation, now open up for our dialogue, our question and answer, and just a reminder to our audience to submit your questions, to open up the Q&A panel and type your question to all panelists, and then we'll be able to see those questions. I'm happy to be joined now by my colleague, Dara Lieberman, who is the Director of Government Relations at TFAH, who is going to assist with the audience Q&A that's coming forward to direct those to our panelists. So to kick things off, I'm going to start first with you, Dr. Sliberg. You importantly highlighted the way in which CDC has been focusing on and caring for the importance of equity in preparedness and response. And one of the dimensions you spoke about specifically was the Chief Health Equity Officer. Pre-pandemic, there were some entities, some states and localities that had this, but this is gaining even more traction and even into policy and into agencies at the federal, state, and local level. And we'd really appreciate you sharing what you've seen as the lessons learned of critical elements when states and localities, when policymakers are thinking about this Chief Health Equity Officer role, how it manifests and what's critically needed to ensure that helps to prioritize and center equity in the preparedness and response.
Yeah, thank you for that question. First of all, I think it's important that I mention that coming out of CDC's Office of Minority Health and Health Equity was where we for decades now have given considerable time to understanding both the science and the practice of health equity. And so in the event of the pandemic, we were able to leverage the office and its expertise to move right into this role of Chief Health Equity Officer and be able to make meaningful contributions. I think what was critical in that success as well is that the Chief Health Equity Officer was part of the leadership of the COVID-19 response, and that there was a clear expectation that all task forces within the response structure would have a focus on achieving health equity. So the elevation of health equity, the elevation of the experience and the expertise that the Office of Minority Health and Health Equity brought into the response, I think were critical things. I think we also had an opportunity to leverage issues like language access, which are also kind of long-standing public health issues. And we saw in the pandemic that we were put in a position of really having to create prevention messages in more than 60 different languages. So the pandemic just exposed, if you will, sometimes we say laid bare, both our the areas that we really need to focus on more in public health and how diverse our nation is and the things that we needed to do in order to be responsive.
And thank you, Dr. Sliberg, and in particular, as you noted, the importance of leadership and centering it across all task forces and what you also articulated, the existing infrastructure of the Office of Minority Health and Health Equity and how that was critical to then providing that expertise into the response. Dr. Dobbs, let's go to you. And you spoke about, for example, the siloed funding, but also the underfunding to states and the ability to really be able to then address a whole host of public health emergencies. I was hoping you could actually help us kind of paint a picture for us with regards to how states utilize this funding. For example, when we talked about the two of the leading emergency preparedness programs, like the Public Health Emergency Preparedness Program and the Hospital Preparedness Program, declines over many years. How does that impact you within the state of Mississippi to engage in the type of public health emergency response? over the years?
It's an amazing challenge. And let me start off by saying, if we did it right, it would cost less, considerably less, right? If we would build systems that were prepared to take the brunt of the effort, we would spend less. So it's not that we only need more, it's not how much, it's how, more than anything. And going into the pandemic, I think we've seen this over and over again, is, something will happen, it becomes a priority, we fund it, and it declines over time, and people say, we don't need this anymore. But these are things that have happened over and over again. This is not the last pandemic. This is not the last new infectious disease threat. There may be a new flu variant, or there may be a new, mosquito-borne disease, especially with climate change on the, underway. There are always threats. And then with our hospitals, it was really kind of sad, because that was our most vulnerable spot, was hospitals. And that, they really were at the point of folding in a way that we had never seen, especially in our state. Luckily, we made it. So it's short-sighted not to think ahead. It cost us a lot of money. Hospitals are a vulnerability that, if we don't have built-in mechanisms to make sure that they're ready, what they're geared toward is making money on an outpatient basis. And if we don't have their attention and their capacity to be responding to these threats, they don't see themselves as players in the operation.
Thank you for that, Dr. Dobbs, and elevating too, as we know, the challenge regarding hospitals and hospital closures, as you noted, even pre-pandemic, to now the impact during the pandemic itself. Dr. Gounder, let's turn to you. You have been writing prolifically, about the pandemic, the new, for example, the national strategy for a new normal of life with COVID-19. You, in your remarks, you talked about some areas around social determinants, so whether it's in our schools or looking at issues such as economic opportunity with paid sick leave. You talked about communities and the importance of rebuilding community bonds. What recommendations would you have for policymakers, right? As we are in this phase of the pandemic, and as we continue to navigate through the pandemic, what should policymakers be prioritizing at this time as we think about strengthening public health and advancing equity?
Well, it's very difficult to talk about equity without data. So I think regardless of what else you think we need to be strengthening in public health, I think our data infrastructure is probably number one, number two, number three, and everything flows from there. And in terms of COVID specifically, should we be counting every case? That is not really how we do surveillance for most conditions. And what we typically do is random representative sampling from the population, and that is one form of surveillance. We do what's called syndromic surveillance, where you look at how many people show up with a fever and cough, and you get some sort of sense of what are the trends in, again, a composite of viral respiratory infections, influenza and pneumonia, and now COVID. And that should be another metric. Wastewater surveillance is another really important tool. It's not one that has been fully optimized yet. We don't have enough surveillance sites across the country. Sewage is processed differently at different wastewater sites. And then how it's measured, the amount of virus in that wastewater is measured somewhat differently. So those need to be standardized and optimized. But I do think wastewater surveillance will be a really important tool. So that's one kind of data. There's also the data information technology systems, and how do you get that data reported from local and state health departments up to the CDC in a complete, timely, accurate way. Some of that will mean investment at the local level. I can tell you, some of the systems I was using, over a decade ago in New York City, one of the best resourced public health departments in the country, were MS-DOS based systems from the 1980s. So when that is the level of technology you have in the field, where people are having to do data entry into Excel spreadsheets, of course, it's going to be difficult for them to report up to the CDC. But then does the CDC have the ability to standardize how the data should be reported, to require reporting up to the CDC, to have a centralized database? What are the powers that the CDC has? Does it have levers to enforce that? I think these are issues that are being actively debated now, and to what degree the CDC perhaps should be better empowered to manage our national data infrastructure.
Thank you for elevating those critical issues. As you noted, with data and data modernization, some important investments that have begun to be made through the COVID emergency legislation, but the recognition that we need more to really strengthen and shore up those data systems, and it's at all levels, and the interoperability, right, of our data systems as well. Let me turn it over to Dara to take an audience question.
Sure, we're getting quite a few questions, unsurprisingly, about politics and how that influences the work that you all are doing at the national and state levels. So I think I would be interested in Dr. Sliberg and Dr. Dobbs' take on this, but quite a few of our participants were talking about how working on things like health equity can be triggering for politicians or for governments in some states and some communities. So how can CDC and how can public health or other health officials work on promoting health equity or promoting or addressing social determinants in a climate where it may be difficult to talk about those issues with policymakers? So let's start with Dr. Sliberg.
Thanks, Dara. So the first thing that I would say is that health disparities and inequities are draining our entire society. It's not just impacting those populations that are suffering from the disparities. And so one of the things that COVID-19, I think, has actually shown us is the disproportionate impact on these populations, not just related to underlying medical conditions, but also significant social determinants of health as well. So we heard earlier about the impact of not having paid sick leave to be able to stay home. We went through an experience of designating people as essential workers, and those essential workers essentially were people who did not have control over their public exposures in many instances. And so I don't need to recount all of what we went through in the early days of the pandemic, but I think that what is clear is that the lack of equity and the lack of justice has really helped to contribute to this like historical pattern of health disparities and inequities. And what we are doing from CDC is just working very closely with our partners. I will name the Association of State and Territorial Health Officials as one partner that we're working with in order to assist state health departments with how to message and how to engage around these issues, because we do recognize that not everyone views this in the same way. But I think the data is clear that equity is really important in terms of us being able to turn around these historic trends in disparities.
Boy, that's such a great series of questions. If we look at the political context, one of the things that's a really good zone for public health is just to be honest all the time, right? And just, and if you catch flack for it, that's part of your mission, right? And sometimes the politicians are the ones who have to make the hard decisions because there's the ones who are elected. Now, there are zones of responsibility that we need to make sure we protect for public health, isolation and quarantine powers and those sorts of things. So we got to be very, very careful about that. But you got to be honest. And speaking of honesty, when it comes to health equity and systemic racism and structural racism, one of the things that sometimes is helpful is to make it is to help people visualize it. And what I've said before is we have a segregated school system in the state of Mississippi, and it's obvious. Everybody knows it. It's not by law or policy, but de facto, most schools are segregated, especially low-performing schools in the state of Mississippi. And visualizing that reality, I think, brings to force the obviousness of it. And that's obviously not where it stops, but it carries on to neighborhoods and wealth creation in neighborhoods that don't have the same sort of capacity for generational wealth accumulation. So anyway, there's a lot of stuff out there, but I think mostly you just got to be honest and then take the darts when they come.
Thank you. That's very helpful. Dr. Gounder, as someone who's worked in both media and policy, can you talk about how policymakers and public health officials can better work with media outlets to disseminate reliable and trustworthy information, not just about COVID or the COVID vaccine, but about public health overall?
I think, first of all, as a public health official who's communicating, I think it's important to state, here's what we know, here's what we don't know. Also, to be clear about what are the different issues or different factors that are being weighed in making a decision and providing advice. And science is certainly part of that calculation, but very often you have other issues that are being weighed as well, whether that is supply, availability of resources, values, social values of different kinds. I think a great example of this was a discussion of masks early in the pandemic, where many people already suspected that there was aerosol transmission. I remember speaking with aerosol experts back in February, March of 2020. And it was clear that we should really be taking precautions to reduce aerosol spread. But at the same time, we had limited supply, and we really needed to conserve that supply for healthcare workers. Because they were on the front lines. I was on the front lines at Bellevue and so on. We needed those resources available to care for patients. And so I think being very clear about what is the state of the science and what are the other factors involved in, again, in making policy, I think is part of it. I think also in terms of in terms of public health departments doing communication, it's not just through mass media, right? You also have a lot of community outreach that's being done. And I think that is most effective when it's done through community organizations, community-based organizations that already have relationships in the community and history in the community. But that means that they also need to be resourced and capacitated to do that kind of outreach, to do that kind of communication. And it has not been something that is universally, I think, appropriately resourced in public health department budgets, that they have a robust communications budget, people who are trained in doing communication, whose job it is to do this, who have relationships with those community-based organizations, who can provide grants to those organizations to do this kind of work. And I think one of the lessons of the pandemic is communication is a branch of public health and should be treated as a core function of public health.
Yeah, that's certainly a point that we made in the report as well. Most, especially small local health departments, just don't have that communications capacity, especially for addressing misinformation. Let's question for Dr. Sliberg. So we've seen through some of the recent funding announcements that came out of CDC as a result of COVID response funds, several of them have included health equity requirements and direction for awardees to partner with community-based organizations. Can you talk about how these lessons might be applied to other kinds of CDC funding streams moving forward? Is there a way that CDC can ensure funding is reaching communities that have been disproportionately impacted about different health concerns?
Yes, absolutely. As I mentioned earlier, our core health equity science and intervention strategy, integral to that process is we're taking a deep dive, if you will, into our notice of funding opportunity, structure and template. And we are very intentionally integrating expectations around health equity. And so we've been in this process, for a few months and going through the necessary vetting, but our goal is that there will be integrated within the funding structures expectations for pursuing health equity.
Okay, thank you very much. This is a public health workforce question. So why don't we start with Dr. Dobbs and then Dr. Grassi, if you have anything to add. We've seen reports of hundreds of public health leaders and officials leaving their positions since the beginning of the pandemic. Can you talk a little bit about how some of the stresses over the past 2 years, including political pressures, may have influenced the public health workforce, and what can we do to better support the workforce?
Well, on the support side, I'll tell you one thing that's really easy and was very helpful for me is positive feedback. And I got a lot of it. I got, cards and mail and emails and phone calls from political leaders across the state said, hey, we got you back. So that goes a long way, because if all you're seeing is the negative, that you think that's all that's out there. So, if you can support those who are with you. One of the challenges, and I think this gets to some of the stuff that Dr. Gowner had mentioned before, is preventing the truth, but there are other factors that need to be mentioned, right? And so although there is a strong public health role, finding that balance between economics and safety is not public health's job, right? And it's our job to outline the risks and make sure that we're doing it accurately and fairly and not, overplaying it, but certainly not underplaying it, right? And that's the whole thing. Where we get into trouble is where people change the facts to suit their narrative instead of making a hard decision. And so here in Mississippi, where it was because we weren't forced to make those decisions early on, it was made by political leaders, the mask mandates and those sorts of things, and the business limitations. We didn't get this. We got plenty of fury, mind you, but it was for things that were ridiculous, right? For recommending vaccinations, you're getting death threats for that, which is bizarre. So it's important to have a political structure that's willing to make hard decisions, because public health people can't make political decisions, and if you do, we get extra vulnerable.
So thank you for that, Dr. Dobbs, and just to thank you for being on the front lines of that each and every day in your role as a state health officer, and to every member of our audience who is in the front lines of public health as a workforce. Indeed, it's been such a challenging time, and we have seen that, as has been noted, with regards to workers who have left the workforce or who have had no choice but to leave the workforce. And I think that critically, areas that we address at TFAH in particular are with regards to assuring that, what to Dr. Dobbs had noted, the importance that public health, there needs to be an understanding around the science and the evidence that really drives the decision-making process in public health, and doing even greater outreach and education to ensure that policymakers, other decision makers, other leaders in other sectors see us as a partner and not as being against the efforts that they have, and assuring that there's coordination as well, from the federal to state and local level, and that support exists because these are challenging times, and being able to manage the expectations when, where we're seeing, for example, changing of guidance, helping to understand that, again, this is not a manufacturing of what the data should be, but it's actually, as we learn more about the virus, as we learn more about through the pandemic, that guidance is going to change. And so the importance of that communication and also that leadership support is highly critical. I wanted to touch upon actually something that Dr. Gowner was raising around public health communications, and recognizing that as really a core foundational capability. Indeed it is, when we talk about infrastructure, how critical public health communications is. And yet we don't provide the resources, so that so many, especially small health departments, don't have that capacity. And so that's what makes these investments, as we talk about the need to increase that flexible and sustained funding for these cross-cutting public health core foundational capabilities, is so critically important. And that the messengers at times will be the public health leaders, but at other times should be other individuals who are other trusted members of the community leaders who may be in other sectors, and building and forging those partnerships before the crisis happens, such that when the crisis happens, there are ways to engage with community, ways to engage with other leaders of other sectors to ensure that those messages are well received. It is challenging, and we have much that lies ahead of us. And the thing that we should not do is assume that once the pandemic is over, that the need to engage in this is over, as far as with regards to assuring that people understand the true mission of public health, which is to promote and support and protect the health of all residents.
Thank you. Thank you so much. So I wanted to ask Dr. Gounder this question. What do you think we've talked a lot about sort of some of the challenges, but what have you noticed have been effective communication strategies used to turn the tide in attitudes toward the COVID-19 vaccine or other kinds of public health measures over the past couple of years, especially in hesitant communities? How do you think misinformation's been combated effectively? Be interested in your opinion.
Yeah, I think what I have found most effective, both as a frontline healthcare provider, as well as doing some of this communication at a broader scale, is it really does take patience and time, and curiosity, I would say, is a really important ingredient here. And what I have found to work, particularly with more vulnerable communities of color, is to just take some time and hear about their experience. I'll give you the example of a woman who is a Baltimore security guard. And what was her experience living and working in Baltimore even before the pandemic, her interactions with the healthcare system? What was it like working as a frontline worker, as a security guard at a building in Baltimore? What kind of protections were offered to her and her family during the pandemic when she still had to show up to work and her boss did not? I think asking those questions and showing curiosity, showing that you care about the whole person and their family and their extended network goes a long way. I think people are not going to be open to a recommendation if they don't feel like you care about them and they have good reason to trust you. I will say, I think it has been more challenging to reach out to people who for partisan or ideological reasons are opposed to simple measures like vaccination. I think that has been difficult. And I do reflect on experiences in other settings. And I'll give you an example. I served as an Ebola aid worker in West Africa, and those countries were also in the middle of their presidential elections. And it is highly predictable when you have a scary new pathogen, an outbreak occur during a presidential campaign, that the incumbent will find that very threatening, because you as the incumbent want to say, hey, I got everything under control, things are going well. And so very quickly, whether it's here in the US or in West Africa or on Mars, I think that is what you can expect to happen, that this will become politicized. And, I think that's what had me at least really terrified back in early 2020, seeing how things were unfolding. Because once an infectious disease does become politicized, it is very difficult to backtrack on that, to get back to where it's no longer seen through that lens.
Thank you so much. And I think we have time for one or two more. I think Dr. Sliberg, you might be able to answer this, but what's your perspective on the role of mental health in public health management and in things like a COVID-19 response, and how can we better integrate mental health into public health responses?
Yeah, we've seen the tremendous toll that the COVID-19 pandemic has taken on the mental health of all communities as well as youth. And so we have to think holistically about how we approach our public health practice, to not just be focused on the physical dimensions, but also on mental health, as well as on the social environment. And I'm very pleased to say that CDC is launching a focus on mental health, and mental health a strategy that we can implement at a population level. And so mental health is critical. And I think that also speaking to issues of like social cohesion and connectedness, which is among the social determinants of health, has also shown itself to be critical as people are starting to reconnect with family and friends, and having seen the devastation when we were so isolated, understanding that we were doing those things in the interest of protecting our families, our communities. So mental health for sure moving forward will be key in our public health work.
Thank you so much. And I think we may need to leave it at that, unless Dr. Gracia, you have anything to add.
Thank you, Dara. I would say, we certainly were experiencing a mental health crisis before the pandemic, and like many other issues, have seen just how that has been deepened in the course of this pandemic. And we've also seen the impact on different communities. Trends, we certainly have the data around some of the highest drug overdose deaths that we're seeing in the nation, and also the trends now of suicide and drug overdose in communities of color that have not experienced higher rates of these in the past. And we recognize, for example, what Dr. Sliberg had been addressing earlier, that it's not only the health inequity, but it's these broader social and economic conditions where we experience bias and discrimination, roots of structural racism that really have undergirded much of these inequities that we're seeing. And so it's critical that we as a nation truly address this crisis that we're facing, and that it has to be across the spectrum from prevention to treatment and recovery, and ensuring that there is equitable access, ensuring that the community conditions, whether it's in our schools for our youth, there's a lot of attention, the Surgeon General, releasing his advisory on protecting youth mental health, to the president with a national strategy on the mental health crisis. These are going to be important efforts for us moving forward to assure that we truly strengthen what is also a fragmented system around mental health and well-being. And that includes prevention in our schools and in our communities, and in investing in programs that actually support social emotional learning, that supports safe and supportive learning environments, to also ensuring that there's equitable access to treatment and recovery and supports that address the broader social and economic needs of communities. So Dara, I think that was our last question that we're taking for today's briefing and webinar. And in closing, we certainly want to thank all of our panelists for their excellent remarks, their input and recommendations and experience and expertise that they've provided in the course of today's discussion. Dr. Sliberg, Dr. Dobbs, Dr. Gounder, we truly appreciated your input and experience. I would also like to thank our staff and team at Trust for America's Health, who have been working extremely hard in putting all of this together. To our captioning service, AI Media, for providing captioning services during the course of the briefing, and to all of you in our audience for participating, for the work that you do each and every day, for your support of this work of ensuring that we strengthen our nation's public health system to assure that we are better prepared as a nation across all hazards, whether that's disease outbreaks to disasters and weather-related emergencies or other types of emergencies. That for us to truly have a strong and healthy and resilient nation, we have to take this call from this pandemic as the clarion call for action, to not return back to the way we have in past public health emergencies. It is really time for us to take action, to invest in our public health system, to assure that everyone has a fair and just opportunity to be as healthy as possible. And so as we continue our work to respond to the pandemic more broadly, let us prepare for and be ready to prepare for and respond to future emergencies. I'd like to thank all of you. Our recording of our webinar today, along with the slides and additional resources, are going to be available on TIFA's website at tifa.org in the coming days. And again, we thank you for joining us for today's briefing and national webinar. Take care, everyone. Stay safe and be well.